Hi, this is Paige Navarro, and this is our head-to-toe assessment for Maryville University Advanced Health Assessment. This is our practice patient, and he's going to read our release statement.
I, Hayden Bowen, voluntarily give Maryville University permission to record my image and or voice and grant Maryville University all rights to use this recording in any medium for educational or other purposes that support the mission of the university. I understand that the following information will be gathered by a Maryville University student as part of course assignment. I give my express consent for this information gathering and physical assessment to be filmed and posted in the student's course shell for access by faculty and students at Maryville University. I further acknowledge that since the recording is for educational purposes only and the information is not meant to be diagnostic, therefore Maryville University, the faculty, staff, and students are not considered liable. The recording will be deleted by the students in any of their devices as soon as it has been reviewed and graded by the instructor.
Perfect, thank you. Okay, perfect. So I have made sure to introduce myself to the patient. I've done hand hygiene, made sure that we're in a private environment. So I can now start our assessment. We're going to start with the head and the face just by inspecting the area for any abnormalities. Then we'll move on to the ear, nose, and throat and eyes exam, starting with the eyes. Rotate this way just a bit. So first I'm going to just use the ophthalmoscope just to look in both of his eyes. Looking at the pupil change in both of them, and then looking for the red light reflex, the optic disc, and the retina in both sides, and also looking at the eye itself, the conjunctiva, the sclera, the lacrimal apparatus, and for any abnormalities in the eye itself, and the lens or the cornea or any of that. And then we can move on to the ear assessment. And while we're doing the eye assessment, we'll also want to check for visual acuity with the Snellen chart. So to do this, I would stand about 20 feet away from the patient or 6 feet away from the patient, and then have him read each of these lines. And then that'll help us check visual acuity, which is also cranial nerve number 2. And along with eyes, we can also use our pen light to assess the extraocular movements. That'll assess cranial nerves 3, 4, and 6. So follow my light. And this moves, we'll have him move his eyes in all visual fields to assess each one of those cranial nerves. Perfect. Now we can move on to the ears. We'll use our otoscope for that. Then we'll want to look, first of all, at the external ear and the auricle, the external ear canal, just to look for any abnormalities or serum or discharge or any impaction of the serum there. And when we look at the internal ear, we're looking at the tympanic membrane to see if it's boggy or to what color it is, and also look for serum in the internal ear. Both of those look good there. And while we are assessing the ears, we can assess cranial nerve number 8 by doing the whisper test. So I'm going to say one word behind each ear and then have him repeat the word back to me.
Flower.
Basket.
Basket.
Perfect. So the ears look good on both sides. Moving on, we can assess the nose, and here we look externally first just for any abnormalities and asymmetry, and then we can use the light on our otoscope to look at the internal nose for any abnormalities, any bleeding or discharge or redness, anything like that. We can also look at the mouth from here. And here we're looking at the oral mucosa, mostly looking at coloring and any abnormalities with the teeth or the tongue or the gums or the back of the nasopharynx as well. And at this part we can assess cranial nerves 9 and 10 with the gag reflex and the swallow, And then cranial nerve 12 we can assess with the tongue movement. So we'll have the patient stick their tongue out, lift it up and down, into the side. Perfect. Moving on, we can now assess just the face in general for any discoloration or abnormalities. And here we can assess cranial nerves 5 and 7 while assessing the face. And then we'll move on to the neck. Here we want to make sure that the trachea is midline, and we can also assess the thyroid here as well. And then this part we can also assess the lymph nodes. Switch around to the front. So here we can assess the preauricular and posterior auricular lymph nodes, the occipital lymph nodes, and the tonsillar lymph nodes, submental lymph nodes here, or submandibular lymph nodes here, submental here. And then we can move on to the cervical lymph nodes, the superficial cervical, posterior cervical, and then the deep cervical chain as well. And then the supraclavicular lymph nodes here also. After we have assessed all the lymph nodes, there's no abnormalities there, so we can move on to respiratory. Respiratory, we first want to just inspect the chest in general, assess the rhythm and rate of breathing and the work of breathing, which all looks normal. And then we can listen to each of the lung lobes. We want to do this from posterior as well as anterior. So starting with posterior, have the patient take deep breaths in all lung fields here. And then move around to the front and assess lung fields here. And then at this point we can also do percussion on the lungs to assess for consolidation. So we'll want to do this in each of the areas of the lobes of the lungs here. And then we can also do a couple tests, additional tests to check for consolidation, which are bronchophony and egophony. The bronchophony is where I'll have him say 99 as we move around to each lobe.
99, 99, 99, 99.
And then egophony is where I'll have him say E as I move the stethoscope around each.
E, 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 E.
Which all sounds normal there, so that's perfect. Next we can move on to cardiac. First thing we're going to want to do with cardiac is palpate for the carotid pulse. We can also auscultate the carotid artery for any bruits. We can look at the JVP here as well. And then moving on, we'll just listen to all the heart sounds. Aortic valve, pulmonic, Erb's point, tricuspid, and mitral, which all sound normal. And then at this point, we can also feel the point of maximal impulse, which would be midclavicular line at the 5th intercostal space there. And then we can also auscultate for mitral stenosis, and at this point I'll have him lie down so we can do that. And it's heard best for mitral stenosis having the patient lie on their left side and put the stethoscope where the mitral valve would be. And that appears normal too. Okay, go ahead and rotate over. We can now move on to abdomen. So the abdominal assessment will start just by inspecting the abdomen for any abnormalities, and then we can also listen to the different arteries of the abdomen, starting with the aorta, the iliac arteries, the renal arteries, and then the femoral arteries. And then we'll want to auscultate each of the quadrants of the abdomen. Which all sound normal. At this point we can also palpate the aorta for the width. Perfect. And then the first thing that we'll want to do is a light palpation in each quadrant, just to assess for any masses or any abnormalities or tenderness. And then after you do a light palpation, then you can do a deeper palpation on each of the 4 quadrants. This deeper palpation will also help you figure out where the liver border is, which should be up in this general area. And while assessing the liver, we can assess for Murphy's sign, which is a sign of cholecystitis. So I will palpate in the right upper quadrant while the patient holds his breath. And if there were to be tenderness here, then that could be a sign of cholecystitis. There's an additional 3 tests we can do here to check for appendicitis. The first one being Murphy's point, which is a line, you take a line from the umbilicus to the iliac crest, and then halfway in that line, if you palpate there and there's tenderness, that could be a sign of appendicitis. We can also check for roving sign, where we palpate in the left lower quadrant, and then if there were referred pain to the right side, that could be a sign of appendicitis. And then psoas sign we could also do by having the patient bend their leg, and then if there's resistance as I try to, or if there's pain when I try to push down on his leg, that could be a sign of appendicitis as well. Moving on from here, we can assess the peripheral vascular system, starting with upper extremities. We'll first start by feeling for lymph nodes in the epitrochlear area, as well as the axillary area. And then we'll feel the brachial pulse here, and then the radial pulse here. And we can do that on both sides. And then moving down to the lower extremities, we can again feel for lymph nodes by palpating the inguinal area, and then we can feel the femoral pulse, the popliteal pulse, and then the post-tibial pulse, and then the dorsalis pedis pulse on the top of the foot. And then moving on from here, we can do our musculoskeletal exam. I'll have the patient sit up. This might make it a little easier. Okay, so we'll first assess the neck with flexion and extension of the neck, which looks good. And then we can assess the shoulders. This might be easier if you stand. And then, so flexing the shoulders and then extending the shoulders back. And then we can also do a test for adduction and abduction of the shoulders. Perfect. And then we can assess the elbows for flexion and extension. Flexion and then extending the elbows. Same thing with the wrists, and then extend and flex. And at this point, we can also check for carpal tunnel by doing the Fallon's test and the Tinel's test, where you tap on the nerve here, and then if that were tender or cause numbness, that could be a sign of carpal tunnel. Okay, and then we can move on down to the spine, where we have the patient rotate, and then flex by bending over and touching the toes, and then extend by arching back, which looks normal. And while he's standing, I'll also jump into a little bit of coordination and assess his gait. So if you want to start here, and then just walk a couple feet just to assess gait. Perfect. Okay. And then also while we are here, we can assess for the hip flexion by bringing both knees up one at a time to the abdomen. Yep, perfect. Okay, now go ahead and lie down again, and then flip over onto your stomach actually. We're going to assess the extension of the hip by having the patient bring their leg up and back. Perfect. Okay, now you can flip back over. And we'll continue assessing the hips by assessing abduction and adduction. So if you bend your knee and then bring your leg across your midline and then out. Perfect. And then you can straighten it back out. And then we can assess the knee from here as well by bending the knee again, and then just moving the lower part of your leg in and then out. That's internal and external rotation. And then flexing and bending, which he did by doing that other motion. And then if you sit up one more time, I'm sorry. We can assess the feet by having the patient bend and straighten out the foot. That checks flexion and extension. Perfect. And then from here, we can also assess a little bit more coordination by having the patient bring his hand to the nose on each side. And then again by crossing the heel over the shin on each side to check for lower extremity coordination. And we already assessed the gait. And then also at this point we can move into neuro. I'll first have him stand and then make sure that he can stand for 30 to 60 seconds with his eyes closed just to check for his balance. If he were to sway or start to stumble, then that could be a sign of abnormality there. And then we can check pronator drift with the hands up with palms up. And then this is done from anywhere from 0 to 30 seconds. If one of the arms were to start to droop, then that could be a sign of an abnormality as well. And then here we can also check for grip strength on both sides just to make sure that they're equal on both sides. Perfect. And go ahead and sit back down. And then we want to make sure that we do the deep tendon reflexes here as well. So we can start with the brachial reflex with our thumb across the tendon here. And then we can move on to the tricep reflex with using the reflex hammer on the tendon behind the tricep. And then the brachioradialis reflex as well there. And then we can move on to the knee jerk reflex. Perfect. And then the heel reflex as well. Perfect. And while we're doing this assessment, we will also be examining the skin throughout, noting any abnormalities, any skin changes, rashes. In the legs, we can assess for symmetry or any edema, for swelling, discoloration that might be happening there. Let's see. And then the last thing that we can do is check the ligaments on his knees for any meniscus injury. So go ahead and lie down one more time. So here we can have the patient bend their knee, and then if the heel goes here, and then I try to push out on the heel, and then push in on the knee, if that were to cause any pain or clicking, then that could be a sign of a meniscus injury. And then the only other things that we would want to do are assess the last cranial nerve, which is cranial nerve 12, by having the patient shrug their shoulders. But other than that, we've assessed all of our cranial nerves and we've assessed all of our body systems. So that is the end of our head to toe assessment. Thank you.